fingerprint indicator on there, that's your clue to focus on that. That's high yield information. So no change on that. All right, this is our course terminal objective. Really no change from our last encounter. And then these are our enabling learning objectives. I do recommend that you review these so you can understand what we're going over, why we're going over it, and then it puts you into that clinical setting. So as we're going over these slides, still put your mindset into that clinical setting for diagnosis, treatment, next step. Okay, so this is just an example of a normal oral pharynx. Just kind of pay attention to how the tonsils look, so really not visible, probably like a +1 here. The uvula, that pinkish color, that posterior arch, how everything is, you can visualize the posterior aspect of the oral pharynx. Taking a look at the palate up here, the tongue. So this is what normal looks like. Then going into some abnormal findings, which will associate with different diagnoses, those swollen tonsils, so that excudate here, that's so not scrapable, right? That's like pus-filled. Think about it like bacteria buildup. So it's not like thrush where you can scrape it off and remove it. You can see how the uvula has a mild deviation there, some erythema, looks very glossy in the posterior pharynx. Here specifically, you see bilateral swollen tonsils, so that's going to clue you in for a tonsillitis as opposed to an abscess. So we'll talk about that, but just kind of paying attention to some of the differences for normal and abnormal. So for pharyngitis, tonsillitis, and infectious mononucleosis, so these are going to be, again, like the bread and butter, about 10% of our encounters. So it's good that we are able to differentiate these diagnoses because a lot of them are clinical. We can perform our physical exam, we can get the history and the HPR from the patient and make a clinical diagnosis, sometimes using testing and imaging if needed. About 50% of these patients do get antibiotics, and we'll kind of talk about that. But just remember that not all sore throats are strep. And we'll talk about strep, so streptococcus pharyngitis, group A beta hemolytic strep, so those are the same things, we'll kind of talk about that. So the most common cause of pharyngitis is a viral cause. So not specific to rhinoinfluenza, adenovirus. It is some literature out there that shows some are more prevalent than others, but understanding that the most common cause of pharyngitis or tonsillitis is a virus. Bacteria can also cause pharyngitis or tonsillitis. Most common cause of bacteria, pharyngitis or tonsillitis, is group A beta hemolytic strep, also known as Streptococcus pyogenes. So those are the same type of bacteria. Gonorrhea, chlamydia also can cause a streptococcus, or excuse me, a pharyngitis. So it's going to be important for us to get a good history as to what the patient is doing. And then that diphtheria is also a cause. For mononucleosis, so the cause of mononucleosis is the Epstein-Barr virus. It is a viral cause. Just note that. So continuing on again, we know that the most common cause of pharyngitis is secondary to a virus. So those symptoms, that rhinorrhea, nasal congestion, sneezing, cough, that is how the patient is going to present to you. But those are very vague symptoms. So it could be viral or bacterial. So we have to get more into the HPI and perhaps do some labs, which we'll talk about. So treatment, primary treatment for viral pharyngitis or tonsillitis is going to be symptomatic, which comprises of everything here. And this is really in sequential order. So saltwater goggles, we can do those, benzocaine, the cough drops, analgesics, NSAIDs, corticosteroids. We can do a short course of prednisone if the patient's symptoms are that severe, but we don't want to just jump to prednisone if we can probably do something a little bit more conservative for them. And you can prescribe multiple of these on their first encounter. So, and then the treatment for bacterial pharyngitis, tonsillitis. So we can prescribe them symptomatic treatment, but because the cause of this is a bacterial cause, we have to prescribe antibiotics. So most common cause is the group A beta hemolytic strep, also known as Streptococcus pyogenes, and then we went over the Neisseria gonorrhea, chlamydia, mycoplasma, and the diphtheria as well. Those are less common. So kind of just going into some of the pathogenesis. So patient contracts Streptococcus pyogenes, that bacteria. It is spread person to person through air droplets, replicated. It adheres to the respiratory tract and replicates, and then the patient develops the symptoms. So fever, 38 degrees Celsius or 100.4 degrees Fahrenheit or more, that's what we consider fever. That tonsillar exudate, anterior cervical lymphadenopathy, very, very specific, because we'll talk about why it has to be that anterior cervical lymphadenopathy as opposed to this general lymphadenopathy, which is inflammation of the lymph nodes, because we have lymph nodes everywhere, axillary, in the neck, deep neck, superficial neck lymph nodes, but specifically the anterior cervical lymphadenopathy. And then that odynophagia, so that's painful swallowing. Going into our physical exam, so that scarlatiniform rash, so it's kind of described like as a sandpaper rash. It may have like that petechial color, that redness, again, that tonsillar exudate or that anterior cervical lymphadenopathy. These are the physical exam findings we will see on a patient that has group A beta hemolytic strep. Some lab tests that we should consider are the rapid antigen detection tests. So this is something that we can do in clinic. It's extremely fast. It's fairly sensitive. It's not the most sensitive, but this would be our first step. We can get it within 15 minutes. We can train our medics to do the swab, perform the antigen detection test, and we can have results. Like I said, it's not the most specific, but it is an option for us. Generally, kind of stepping out of academia, I do both. I do rapid antigen detection tests, and I do the throat culture, but just kind of taking that stepwise approach. So then our next option would be the throat culture or the swab. So that's where we get a swab from the patient, and we send that off to the lab. Depending on your capabilities in that military treatment facility, you may be able to get it back within 24 hours. Usually it takes about 72 hours to get that back. But that's why we can use our rapid antigen detection test to see if the patient has group A beta hemolytic strep or strep throat today. Because a lot of the patients are going to want to know, do I have it or do I not? And what medication I need to take, what precautions I need to take. They don't want to spread it to their family members, that kind of stuff. And we can also do a CBC. We might see some indication of infection, because this is an infection, so those elevated white blood cells, but not required. Okay, so we're specifically talking about strep pharyngitis. So the Centaur score and modified Centaur score, these are assessment tools that we can use to determine our treatment for a patient that we suspect has strep pharyngitis or strep throat. All right, so this criteria, the patient gets 1 point for each of these criteria. No cough, tonsillar exudate, anterior cervical lymphadenopathy, and then if they have the fever over 38 degrees Celsius, right? And we'll talk about what drives the treatment. The modified Centaur score, so essentially they're the same thing. The modified Centaur score is just more specific because it incorporates age. So if a patient is between the ages of 3 and 14, they get 1 additional point. If they're between 15 and 44, it's 0 points. And then if they're over the age of 44, you subtract 1 point. Any questions on that? Because this will be like the baseline for some of our questions. All right, so the reason that we care about all of this is so that, because strep pharyngitis is fairly common, right? Like, has anybody ever had strep throat, or maybe children that had strep throat? So it seems like, oh yeah, we can treat it, whatever. But if it goes untreated, it can sequela into very complications like glomerulonephritis, rheumatic fever, and you'll kind of discuss these things in other classes. But think about bacteria getting into the bloodstream, affecting organs that filters blood, that bacteria attaching to those organs, that kidney, that heart, and then essentially it can lead to either severe illness or death. So that's why we care. The goal of treatment is to prevent that rheumatic sequela. Going into our treatment guidelines. So what we just talked about specifically for the modified Centaur score. So if we calculate the patient's score, if they between 0 and 1 points, no antibiotics, we can just do symptomatic treatment. Can somebody give me an example of symptomatic treatment? Say it loud and proud. What was it? NSAIDs? Tylenol? Barbitol? Yep. Okay, perfect. So no antibiotics, right? Between 0 and 1 points. If it's 2 to 3 points, our next step in management is going to be to perform a rapid antigen detection test or the throat culture, right? So that will be our next step if you calculate between 2 and 3 points. And then if they have 4 or 5 points, we can skip and just prescribe antibiotics. We don't need to perform the rapid antigen detection test. We don't need to perform the throat culture. You can just prescribe them antibiotics, but I'm going to tell you, just kind of step down to academia. They're going to want to know. So it's okay to perform that when you're in clinic, and you can make that clinical judgment. But for the course, understand if they have between 4 and 5 points, you can prescribe antibiotics as your choice in management. Any questions on that? This is just going into some of the symptomatic treatment that we already discussed. All right, so we get a patient and we calculate their modified Centaur score as a 4, and we decide to prescribe antibiotics. Our first choice of antibiotic is going to be penicillin V. That is the oral form of penicillin. I was looking into this a couple days ago, so because I'm like, what is V, right? But really, it's just the 5th generation of this penicillin, right? And V it's more, it can handle more acidic natures. So like the stomach is very acidic, so it will still be effective as if you see like penicillin G, where it's an intramuscular delivery of penicillin. That is not really conducive to those acidic environments, and it's not going to be as effective. So that's why it's penicillin V, and that's the oral form of penicillin. We can prescribe a cephalosporin. We'll talk about refractory treatment in the next step. If the patient has a penicillin allergy, though, we want to stay away from penicillin, and we're going to prescribe erythromycin. It does have a 25% failure rate, but we much rather take the failure rate over an allergic reaction. So we won't prescribe them penicillin. And then we want to avoid cephalosporins if they have a penicillin allergy, because it is some literature that shows cross-sensitivity between penicillins and cephalosporins. So we still want to avoid cephalosporins if they have a penicillin allergy. So this is just kind of guidelines for strep pharyngitis treatment. So we can repeat the regimen. In my experience, patients do not take the medication appropriately. They might skip days or decide to take it all at once, and and then they come back and they're still symptomatic. The strep has not resolved, so we can repeat and reiterate patient education on how to properly take the medication. So that would be our first step. And then if they do complete the medication appropriately, then we can move on to trying a cephalosporin. These are just some admission criteria that past medical history of rheumatic fever, glomerulonephritis. If a patient has airway compromise, signs of airway compromise, we definitely do not want to send them home with an oral antibiotic, because they probably cannot even consume that oral medication. Oh, what would be some signs of airway compromise? Stridor, yes, very good. What was that? Cyanosis, yes. Anything else?
Tripoding.
Tripoding, yes.
Just a question on the cephalosporin.
Uh-huh.
Okay, so that's the second line. If the Pen B fails, can we retreat with Pen B again? Am I understanding that correctly, or am I?
Yes. So what I would do is start with Pen B. If they confirm that they've taken the medication appropriately, Re-prescribe Pen B. If they fail, then cephalosporin. Yeah,
So Pen B twice,
and then
and
cephalosporin.
still no resolution.
Cephalosporin.
Thank you.
You are. All right, these are the complications that we kind of already went over, but just going into a little bit more detail, like we were talking about that rheumatic fever, where that bacteria, it attaches to the valves of the heart. Remember, the blood is flowing through the heart, so it can be easily attached there and infect the valves. The glomerulonephritis, and then that local abscess, so that peritonsillar or retropharyngeal, which we'll talk about, where that's even more posterior, the most posterior in the oral pharynx, so they can also develop an abscess there. And an abscess is just a pocket, it's like a pus-filled pocket of bacteria, and we'll talk about that. These are just other causes of pharyngitis, tonsillitis, because that's where we still are. I know we harp on streptococcus pharyngitis because that is the most common thing that we see, but just understand there is some other bacteria that can cause this. So we want to make sure that we get a good history from the patient, right? Even including sexual history. Like, we need to understand what is our differential diagnosis with this patient. Is it because if the throat culture comes back negative, then where do we stand? So we got to make sure we get a good history, and we can perform other tests as well. All right. Can I get a volunteer for the first question?
20-year-old male reports to the primary clinic with sore throat times 4 days. He reports dysphagia, fatigue, malaise, body aches. He denies cough and nasal congestion. He denies allergies. Vital signs are as follows. Physical exam reveals tender anterior cervical lymphadenopathy and pharyngeal exudate. What's the patient's Centaur score?
What are we thinking? Okay. Somebody said 5?
4.
4? Yes, 4. Okay, let's walk through this really quick. So the patient is 20 years old. Does he get a point for being 20? No points. Okay, patient has dysphagia, fatigue, malaise, body aches. Any points for that? No points, right? He denies cough. Point. If a cough is not mentioned, he also gets a point. Don't assume that the cough is there if the cough is not mentioned in the symptoms. Does that make sense? So if you have a scenario and the scenario says, does not mention the patient has a cough, don't in your mind, don't think about, do they have a cough because it's not there. Does that make sense? People are like, oh. Okay, I'm gonna take that as yes. All right, he denies cough. 1 point. Does he get a point for nasal congestion? No points there. This patient does not have allergies. Okay, let's look at his vital signs. Does he get a point for any of his vital signs? Fever, 2 points. Physical exam. Does he get a point for the tender anterior cervical lymphadenopathy? Yes. Does he get a point for pharyngeal exudate?
Yes.
Really? Is it tonsil or pharyngeal?
You don't know.
Yeah, so pay attention to that. So tonsillar exudate, not pharyngeal exudate, and we'll talk about, is it a tonsillitis pharyngitis? Is it in the tonsillar capsule? So just kind of pay attention to that. Other things like if a patient has erythema on the tonsils or has exudate on the tongue, that's not a point. So it should be 3. All right, let's go through the next one. I think this one might be a little different. Yeah, if I could get a volunteer.
25-year-old female reports to the primary clinic with sore throat times 4 days. She reports fatigue, malaise, and body aches. She denies cough and nasal congestion. She denies allergies. Vital signs are as follows. Physical exam reveals tender anterior cervical lymphadenopathy and tonsillar erythema. Which of the following is the most appropriate next step in management?
All right, first let's walk through and calculate the patient's Centaur score. Do they get a point for age? No point for age. What about their, so they get a point for, which symptoms do they get a point for? No cough? And then what vital signs do they get a point for? Fever, physical exam findings, lymphadenopathy, and what else? and the tonsillar exudate, so that's 4.
It says up there.
Oh, thank you. I'm just making sure you guys are paying attention. 3. Okay, no, good job. I thought I read this today. Okay, 3. So which of the following is the most appropriate next step in management? The patient has a 3. What are we gonna do? Yes, rapid antigen detection tests. All right, and then you guys understand, so symptomatic treatment only, no, we wanna test the patient, we don't wanna just send them home. We wanna see what if we can do something at the level of a primary care provider, we wanna do that. We do not want to jump to antibiotic treatment. Their Centaur score is not a 4 or 5. C, we went over that. Refer to ED for admission. That would be inappropriate use of resources. And then order a complete metabolic panel, maybe further down, but not right now. The most appropriate next step in management is to order that rapid antigen detection test. All right. Another volunteer. It looks like you're like the spokesman.
42-year-old male reports to primary clinic with sore throat times 4 days. He reports fatigue, malaise, and body aches. He denies cough and nasal congestion. He denies allergies. Vital signs are as follows. Physical exam reveals tender anterior cervical lymphadenopathy and tonsillar exudate. Which of the following is the first-line treatment for this patient's underlying medical condition?
Thank you. Right side and left side spokesman. All right, so let's kind of walk through it. So do they get a point for their age? No point. What's the cutoff if they get a point for 44? Thank you. Yes. So no point for their age. What about for their symptoms? Anything for fatigue, malaise, body aches? He denies a cough. Point. Fever. And what else? That's 4. So which of the following is the first line treatment for this patient's underlying medical condition? What?
Envy.
Pen B. I thought somebody said Pen G. Okay, Pen B. All right. All right, it's on you. Left side or right side.
10-year-old boy brought to the primary clinic by his mother. He reports a sore throat, fatigue, malaise, body aches after 4 days. He denies cough and nasal congestion. He reports a penicillin allergy. Vital signs are as follows. Temp 101.5. Physical exam reveals tender anterior cervical lymphadenopathy and pharyngeal exudate. Which of the following is the first line treatment for this patient's underlying medical condition?
All right, let's walk through it. Age. 1 point. Yes. What about for symptoms? Which one? No cough. All right, and then so we note that he has a penicillin allergy. What about for his vital signs? Fever. And then for his physical exam findings? Lymphadenopathy. What about? All right. So which of the following is the first line treatment for this patient's underlying medical condition? Echo, because he has the penicillin allergy. Yes. What is this patient's diagnosis? What is it? Yes, streptococcus pharyngitis. Yes. All right. Now going into, we talked about viral bacterial pharyngitis and tonsillitis, going into infectious mononucleosis. So this is a type of viral pharyngitis, but it's caused by the Epstein-Barr virus. A little bit different presenting signs and symptoms in physical exam. So that patient will have generalized lymphadenopathy. So it doesn't have to be specifically that cervical anterior as expressed in that Centaur score. That gray, green, white exudate, just think of it as discolored. So it's not going to be yellow. It'll be off-putting for sure, right? And then that hepatosplenomegaly, so that's where the spleen and the liver are enlarged. Okay, so you will be able to note that on your abdominal exam. Generally, this happens in younger adults between the ages of 18 and 25, but not to say that it can't happen in someone older or younger than that. So some laboratory test considerations. So we can do a CBC. We might see some lymphocytosis, so elevated lymphocytes on that CBC, plus or minus elevated white blood cells as well. But really what's gonna clue us in is that heterophil agglutination test, so that's also known as a monospot. Has anybody ever heard of monospot? Any of the medics, like a monospot test, kinda, yeah? So that's the same thing. That's gonna be our first line or our primary, because again, similar to the rapid antigen detection test, it can come back in like 15 minutes. It's a very quick test that we can do at the family medicine level to evaluate the patient, and then we can also do that Epstein-Barr virus antibody titer, but it might take a couple days to come back. So generally, in clinical practice, I would do both, but if we want something quick, we can do a monospot right there in clinic. Treatment is symptomatic only for this patient. No antibiotics for patients that have infectious mononucleosis. And then we want to provide that patient education and cancel them because they might have that hepatosplenomegaly. So no, we don't want to rupture the spleen. So no contact sports, football, flag football. Nowadays basketball. Yeah. So just kind of educating that patient on the precautions until their infection resolves. This is just a picture of a normal spleen. You can kind of see that enlarged spleen, and then the same thing with the liver equals no football. All right, any questions on what we've gone over so far? Bless you. Yes, sir. Hepatosplenomegaly.
So if you don't have any of that megaly going on, you're good to play, right? Like if you don't have that extreme fatigue,
I would honestly,
you still cancel.
yeah, I would probably not cancel them not to, because that kind of stepping out of academia, that's still your license on the line, and maybe you just didn't perform a great exam, or maybe it develops. Just kind of being honest because we practice medicine. So I would still cancel them not to, especially if they had a positive monospot or that titer was positive. I would say, for 2 or 3 weeks until it resolves, no contact sports. Just so you've done your due diligence. Whether or not they listen, that's really on the patient. All right. Okay, we're doing it on time. Any other questions on strep pharyngitis, mononucleosis, viral pharyngitis, modified centaurospore? Okay. So going into peritonsillar abscess, retropharyngeal abscess, and cellulitis. So just kind of going into some generalized terms. So peritonsillar pharyngitis or cellulitis is infection that penetrates the tonsils. The tissue around the tonsils. So peritonsillar, it'll be in that posterior oral pharynx. Peritonsillar abscess or quinsy, so that's when they develop a pus-filled pocket or purulent pocket around the tonsils, and we'll talk about that. And then tonsillitis is infection of the tonsils, and usually that's bilateral as opposed to with the abscess, it'll be unilateral. And then that retropharyngeal abscess, so same thing, pus fluid, a fluid-filled pus pocket, but you can see how posterior it is in the oral pharynx, that retropharyngeal space. So that's usually a pretty severe complication. Still the same cause. Think about PTA as a sequela from strep pharyngitis if not treated. Right, so that Streptococcus pyogenes or group A beta hemolytic streptococcus is the same bacteria that causes strep pharyngitis or an abscess. You guys need a break? You doing okay? No break? Okay. So this is just kind of going over the pathogenesis, so tonsillitis, kind of what we talked about, not in the correct order though. Then it can, so that capsule, usually in tonsillitis, that capsule is not, that the bacteria doesn't penetrate to get into the peritonsillar space. So if it does, then it can sequela into peritonsillar cellulitis, pharyngitis, peritonsillar abscess, or retropharyngeal abscess. All right, so symptoms of a patient with a PTA. Usually severe sore throat, dysphagia, so painful swallowing, difficulty swallowing. On physical exam, they may have like a hot potato voice, so where it's like effortful speaking, like very wispy. I wish I could like impersonate it, but it would be very bad if I tried. And then that medial deviation of the soft palate. So the soft palate will, and we'll look at a picture, but it'll deviate down, pushing the uvula to the opposite direction because of that pus-filled pocket, uvula displacement, and then the tonsils or the peritonsillar tissue may become fluctuant. So that's where it's kind of squishy, that glossy look that we saw in the other picture, or that trismus where they have difficulty opening and closing their jaw. And this is an example of that. You can see the medial deviation here. So this is where the peritonsillar abscess is, and it kind of deviates, pushing that uvula away from the medial aspect. So labs that we want to consider, again, we can do a throat culture, CBC. Imaging is not required. This is a clinical diagnosis. If you see it, don't second guess it. It is a PTA. It's pretty obvious. We can do an ultrasound, and we'll talk about that when we need to do a fine needle aspiration to kind of guide us, or we can do a CT, but it's generally not necessary. So treatment for a PTA. Starting antibiotics, fluids, analgesics is generally, it's going to be simultaneous. The key here though is we have to control the source, which is that pocket full of pus that has the bacteria in it. So it's either going to be a fine needle aspiration or it's going to be the IND. It's a lot of controversy about which one is the best. You know, once you gain your clinical bearing, you can decide which one you would like to do. Some consider the fine needle aspiration a little bit less invasive than the IND because you do have to like implement like a 1-inch incision on that abscess. So it just depends. But the key here is to know we have to start the antibiotics. We got to get the patient fluids, and we have to control the source using either fine needle aspiration or doing the IND. This is just a depiction of the deep vascular space. So we have risk factors associated with performing these procedures. Biggest thing, that carotid artery and also that jugular vein in relationship to a peritonsillar abscess. So we want to make sure that we don't penetrate too deep within that abscess and penetrate an artery or a vein. And this is just an example of where we would place the needle if we were going to perform a fine needle aspiration. And you kind of see that superior middle pole. Kind of want to stay away from that carotid artery, that jugular vein. For incision and drainage, like I said, it is a little bit more invasive because we are making an incision. And it depends on your setting as well. You can see there they have suction, and they're also able to visualize that abscess. They have that camera there. So it just depends on your setting, what tools you have available to make that determination if you do fine needle aspiration or if you do an IND. Now, if a patient has recurrent PTAs, chronic infections, then we might need to consider doing a tonsillectomy, because just thinking about where the tonsils are in relation to the posterior oral pharynx. If they have large tonsils, bacteria can harbor on those tonsils and they can be more prone to a PTA or tonsillitis. So that would be some considerations for referring a patient to ENT for a tonsillectomy. And then these are just some complications of a PTA. So we kind of talked about the retropharyngeal abscess, deep neck infection. We'll talk about that, not next block, but the block after that. And then pneumonia as well, because just kind of thinking about the anatomy, the lungs and the oral pharynx and the esophagus, everything is in such close relationship, so that bacteria can spread to the respiratory system and cause a pneumonia. Check on learning. I think we're on the right side. Oh yeah, we got another volunteer.
25-year-old female presents to the emergency department with a sore throat, difficulty swallowing, and trouble opening her mouth wide for 8 days. Vital signs are remarkable for fever. On physical examination, she has a medial deviation of the soft palate and peritonsillar fold. Which of the following other physical examination findings is most likely to
So what do we think this patient's diagnosis could be? What is our primary diagnosis? PTA. Okay, kind of going through, what do we think for, what was that? Yep, muffled voice, hot potato voice, exudate on the tonsils, that's more of a pharyngitis thing, white patches on the tongue, probably thinking yeast, exudate on the wart and stuff, not applicable, mass on the parotid gland, not really applicable either. So. All right, can we get another volunteer from the right side? Anybody on the right? Oh, right. What are we thinking? Which of the following is a physical exam finding in a patient with a PTA? Trismus, yes. That's difficulty opening and closing the jaws. Yes. Bilateral tonsillar atrophy, that's probably more of a tonsillitis. Tonsillar exudate, the same thing, pharyngitis. Painless cervical swelling, that could be anything, honestly. That's just lymphadenopathy. Vesicles, should be vesicles, or vesicular lesions on the tonsils. Maybe HSP, but definitely not a PTA. All right, I think this is our last one.
17-year-old. Go ahead.
Right side. Next time I'm gonna bring a name sheet and just like start calling people out.
A 17-year-old female presents to the emergency department with a 3-day history of worsening sore throat, fever, adenophagia, and trouble opening her mouth wide. On physical examination, she is febrile, 102.4 degrees Fahrenheit. There's unilateral tonsillar swelling with deviation of the uvula to the opposite side, muffled voice, and tender anterior cervical lymphadenopathy. Which of the following is the most appropriate management for this patient?
What is this patient's diagnosis? What's this patient's diagnosis? What is it? PTA? Yeah. So PTA, and then what are we thinking for the most appropriate management? IND and FNA, definitely. In addition, yes, antibiotics. So what is your choice? A, for sure. We definitely don't want to just start saline and observe. Even though that is one of the fluids that we start, is not the best choice. Referring to the emergency department for a tonsillectomy, that's if the patient is refractory. Starting IV antibiotics only, that's not going to control the source, so that's not the best. And then start IV antibiotics and order a CT. We don't necessarily need a CT. Remember, this could be clinical. If it's a PTA, if it looks like a duck, quacks like a duck, it's a duck. Any questions?
Ma'am?
Yes.
If we do decide on an IND, do you need to re-suture? Like if you make a 1-inch incision, do you suture it or just let it heal itself?
It depends on how the patient is presenting. Sometimes they will do like absorbable sutures. And sometimes, I mean, it says 1 inch, right? But they might just need to make like a ½ inch incision. So it just depends on how the patient presents and the surgeon. Because in my experience, ENT is typically doing an IND only because they have the equipment to visualize the posterior oral pharynx. Like it's kind of scary to think about like just putting a needle back there and not seeing. But I've seen they've done like 1 suture just to close it up, allow it to close on their own. Yeah, it just depends. Any questions? Any other questions? Okay. All right, that's all I have. I'll stay up here if you have any other questions.